Finalmente se decidió hacer el Congreso por vía virtual. Siempre las primeras palabras, después de un trabajo que demanda dedicación, es simplemente agradecer a todas las personas que han colaborado y muy especialmente a los profesores que hacen un esfuerzo muy especial para estar con nosotros. Un agradecimiento especial a los participantes por tratar de unir su experiencia con la nuestra. Esperamos estar a la altura de sus demandas, esperamos que llene algunos vacíos nuestro evento. Y también esperamos estar más comunicados todos los que tenemos afición por la cirugía de columna. Doctor Vaccaro, buenos días, bienvenido. Doctor Vialle, buenos días, bienvenido. Creo que ya muy pronto podremos estar reuniéndonos en persona. Sin nada más, voy a dar pase al moderador de este segmento. Adelante, José Luis.
Muy bien, doctor Basurco, muchas gracias. Muy buenos días con todos. Soy José Luis Urquizo, neurocirujano del Hospital Nacional Guillermo Menara de Lima, Perú. En nombre del comité organizacional de este gran evento científico virtual de la Asociación Peruana de Cirugía Vertebral, le agradecemos por estar conectados y a todos darles la bienvenida al cuarto Congreso Nacional de Cirugía Vertebral. Daremos inicio a la primera sesión de conferencias magistrales a cargo de dos grandes y muy reconocidos cirujanos de columna en el mundo. En primer lugar, al doctor y profesor Alex Vaccaro. Él ha sido presidente del Rodman Orthopedics desde el 2014 y es profesor del Richard Rodman y chairman del Departamento de Cirugía Ortopédica y profesor de Neurocirugía de la Universidad de Thomas Jefferson en Filadelfia, en Pensilvania. Recibió el premio Leon Wills, otorgado a la excelencia en el liderazgo y a la investigación clínica para el cuidado de la columna vertebral para la North American Spine Society, y es expresidente del Cervical Spine Research Society, y también de la American Spinal Injury Association. Actualmente es miembro de la Junta Directiva de la Academia Americana de Cirujanos Ortopédicos. Tiene muchísimas publicaciones, ha publicado más de 300 capítulos de libros, editor más de 63 libros de texto. Actualmente es codirector del Regional Spinal Cord Injury Center del Valle del Delaware. Ahora el doctor Vaccaro tocará el tema de enfermedad degenerativa del disco lumbar, algunas opciones de evidencia actuales, y por último culmina con cirugía de fracturas thoracolumbar en el paciente anciano. Dr. Alex Vaccaro, welcome, professor, and thank you for your accepting our invitation of this virtual congress of the Peruvian Association of Spinal Surgery. It's a great honor to have you here. We give you the floor so that you can begin your masterful exposition. Thank you very much, Professor Vaccaro.
Thank you, Jose. Thank you very much.
Thank you, doctor. You may share your screen, please.
Yeah.
You have about 20 minutes to develop your topic. Thank you again very much, Professor.
Great. First of all, it's an honor to have the opportunity to speak with you, and I hope that your country is doing well from the surge in the virus. I know we're going through it again, and I hope Peru is not, and no one's suffering, number one. And thank you for allowing me to speak today. So I was asked to speak on two topics. One was on what is the evidence for surgery in the setting of back pain, which is very controversial. And in fact, where I live in Philadelphia, most of the insurance companies will not even consider surgery. So if you have someone with debilitating back pain who can't go to work, they will not cover it, and patients have to pay out of pocket. So I'll begin by saying that we all have back pain. Every time I go to a hotel room, the next 24 hours, I feel miserable because my bed is different. So 85% of us under 50 will have back pain, and extremely, extremely expensive. In our country, because of workman's compensation, personal injury, lost time from work, it is the third most expensive medical disorder, and we have no idea really what causes back pain. Is it the disc? Is it the facet joint? Is it the muscles? We really have no idea because there's so many potential reasons why we suffer. Is it mechanical? Is it due to tumor, infection? Is disc degeneration really an infection? I mean, we're looking at P. acnes right now. Could that be the reason? Or can it be referred pain from a kidney stone, from a hernia, from GI upset? We have no idea. But we do know one thing. When you look at an X-ray and you have degenerative disc disease, that's not always the cause of your back pain. So keep that in the back of your mind. And Scott Bowden, who's now the chairman down in Atlanta, Georgia, has come out with seminal papers that show that by the time you're 20, you may have degenerative findings. I've seen people in high school with degenerative changes. And if you're over 60, over 80, you will have degenerative things. So if you look at an asymptomatic population of patients, a vast majority of them will have degenerative changes. So this one particular study, out of 98 asymptomatic patients, only 36% had normal discs, which is interesting. And if you look at patients who develop back pain over time, and if you follow them serially, only one initially had an abnormal MRI scan. So you could have back pain and have a perfectly normal looking MRI scan. So it's very confusing. So with that in mind, we have to be extremely selective. We have to use experience. And most importantly, we cannot do harm if we subject these people to surgery. Now, discography. I grew up in the world of discography. Everyone used it. I never use it anymore. And if I have someone come into my clinic with a collapsed disc, advanced modic changes, single level, and they're miserable and they've done 6 months of non-operative treatment, I will offer that patient. So when do I do a discography? I do it when I have that, and then the next level doesn't look that good, but it doesn't look horrible. I may do it, but remember, two things that discography can cause. You can cause injury to the disc with the needle and cause the person to have problems. And there's always the risk of infection. So if you look at all the studies, it's very, very non-specific, and the positive predictive value is limited. So use it sparingly. In early 1990s, I used it 100% of the time if I was looking at this diagnosis. Now I use it 5% of the time. So keep that in the back of your mind. And I always tell every patient, a person who's working hard, has a job, isn't divorced, isn't addicted to drugs, I say to them, you have a 50 to 70% chance of getting better. And every single study has looked at it. And I did a humbling study on my own patient populations because I feel my patients do great. They don't torture me. They don't come back, complain. They don't yell at me. Oh, I must do great. So I had one of my fellows go out and look at my patients over a 10-year period compared to those that I signed up for surgery that didn't have surgery. And there was no difference in outcome. So keep that in the back of your mind that the outcome can be the same. So let's look at what data we have. And I accumulated these studies. These are the best prospective, controlled, randomized studies that looked at surgery for back pain compared to physical therapy, cognitive behavior, behavioral changes. So let's take a look at it. And if you break it down, the vast majority said surgery just doesn't work. And then there was a couple of good studies that said, well, maybe it looks. So let's take a little walk through the literature. This was one of the first studies in 2003 by Brock. 64 patients, aggressive conservative treatment with cognitive intervention, educating people about their back pain. Year follow-up, no difference in ODI. Then a follow-up to that, 4 years later, more patients included. This crossover between conservative to surgery. Surgery has about a 23% reoperation rate. And what they find, no difference in outcomes. One of the first good studies that randomized patients. And then Furhold looked at a longer term follow-up. And again, 99 patients in long-term follow-up, no difference at all.
Dr. Vaccaro, excuse me, your iPhone went off.
Oh, I don't know why that happened. This is just a slide that it went off on? Okay.
We can listen to you.
Okay, gotcha. The Fairbanks study, phenomenal study, 349 patients, 15 centers, 173 non-op, 176 operative. And what they found over time was that the ODI was better initially. So this is initially at the 2-year follow-up. Every other outcome was similar. But when they did an analysis of the economic benefit of surgery, there was no benefit. So if they look at society as a whole, even though at 2 years patients felt they were doing better economically in terms of return back to work, it was not any better. And then they did an assessment where they brought it all together. They looked at all the different studies, the Fairbanks study, the Brock study, and they looked at all 473 patients, and they found no difference between fusion, physical therapy, cognitive, and behavioral treatment. No difference at all. Keep that in the back of your mind. Now, the best study out there that said surgery may be effective was very limited. This was an Asian study, 41 patients, 20 minimal non-operative treatment. So minimal non-operative means go do physical therapy, go take medication, go do behavioral. Wasn't really organized compared to surgery, 2/3 anteriorly, 1/3 posteriorly. They did show a significant improvement in ODI over time, which was important, but it was a small randomized study. Now, Fitzel won the Volvo Award in 2001 from the North American Spine Society. 294 patients, fusion versus non-specific physiotherapy, 2-year follow-up, 98%, which is phenomenal. And he did show a significant improvement in ODI and all the other different outcome measures. So phenomenal. Showed a great. Now, one of the members of the spine study group did a long-term follow-up of the same group of patients at 12.8 years. And guess what? No difference. Now, you may say that's important. In the first 1 to 2 years, they did great, which is important. 12 years. So are we operating now for long-term follow-up, or are we operating to improve the quality of life immediately and in the short term? Interesting. So he showed at the end of the day, 12 years. So almost every study except the Asian study showed no difference. So then Biden took it all together, took all the randomized studies and did a meta-analysis, systemic review, and said at the end of the day, we cannot prove that doing back pain is any difference. So the Fitzel, Brock's, Fairbanks, Otari, no difference at all. And you can see a little bit of favoring for surgery, but it wasn't statistically significant. So at the end of the day, because Fitzel showed at follow-up, there wasn't really a difference. Only one study that only had 41 patients shows it's different. So keep that in the back of your mind. Now, does Alex Vaccaro still do back pain surgery? I do. I tell everybody, make it less than 5% of your practice, because as you saw in these studies, some patients feel they got better. And on top of that, you have the placebo effect. But single level degenerative disc disease, it makes sense. Now, what about this push for arthroplasty? There was a massive push in the early 2000s. It's gone away because anterior surgery is complicated, revision surgery is complicated, cervical arthroplasty shooting up, lumbar arthroplasty is not. And if you look at the literature, this just came out of Australia, looking at prospective case series, there's certain names that you will see. Jack Ziegler, Texas Back Institute, Francis Scott Young. They push it and they push it and they push it, and they always show great results. And remember, the company-sponsored studies always showed great results. Keep that in the back of your mind. Always showed great results. But remember, that was a biased population. A recent comparison of disc replacement versus fusion showed that a disc replacement decreased the risk of reoperations, more likely to improvement of ODI, more likely to improve your back discomfort. And that's great. But remember, these are people that do it for a living every day, and we have not been able to sort of replicate those results. Satisfaction has been very good. So that patient on the left is someone I will operate on. That is the only patient I will operate on. But keep it in mind, people out there say the success rate is 85%. I say 70%. But when you put depression, which they all have because they're miserable, they're taking narcotics, you decrease. They may be a smoker, which most of them are because they have miserable back pain. And you put it together and the results aren't that good. So keep in the back of your mind, when you're a young surgeon, it's just not the x-ray and the patient's complaint. Do a deep dive. into the background of the patient, have an understanding, because we have to understand there's so many things causing back pain. We still do not understand it. Hopefully, genetically, we'll come up with a cure in the early stages of it, but we really, really don't know what's going on. So it's a mystery. We don't have a reliable MRI is the only thing that I do. You have to hunt for all the comorbid contributors that may adversely affect the outcome. And I showed you, there's only 7 papers out there that you can really look at that really study this carefully. So where I come from, it doesn't matter if the patient's done everything right and has been treated. The insurance companies won't pay for it. So it's a headache to begin with. So thank you very much for allowing me to share my thoughts on this topic.
Thank you very much, Dr. Vaccaro, for your excellent presentation. At the end of this session, we have some questions from the audience to address to you. We ask you to still stay connected with us, because now you will have a Professor Vialle presentation, and Dr. Vaccaro. Thank you so much.
You're welcome.
A continuación, tenemos también el gran honor de presentarles a otra referencia mundial de la cirugía de columna, el doctor Luis Roberto Vialle. El doctor Vialle es profesor de la Facultad de Medicina de la Pontificia Universidad Católica de Paraná, miembro del Consejo Editorial de las siguientes revistas nacionales de columna, Acta Ortopédica Brasileira, Revista Brasileira de Ortopedia, y también de muchas revistas internacionales como la European Spine Journal, Global Spine Journal y The Spine Journal. Es miembro de la unidad de columna del Hospital Universitario Cajuru y del Centro de Columna Vertebral de Curitiba de la Universidad Católica de Paraná. Fundador y past president de la Sociedad Brasileña de Columna Vertebral, chairman tanto de la ASPECIVE Latinoamérica del 2003 al 2007 y de la ASPECIVE International. Es decir, es el máximo líder a nivel global del año 2009 hasta el 2012. Todo el mundo lo conocemos, es un brillante profesor. Tenemos el honor de tenerlo aquí presente y ahora va a tocar un tema fascinante de lo que es balance sagital y osteotomías. Doctor Vialle, sea usted bienvenido a este Congreso Peruano Virtual y agradecerle infinitamente por aceptar nuestra invitación. ¿Puede compartir su pantalla, por favor? Cuenta con 20 minutos también para desarrollar su tema. Profesor Vialle, le cedemos la palabra y nuevamente gracias por estar conectados con nosotros.
Bueno, en primer lugar, me gustaría agradecer la invitación. Es un placer estar con ustedes, ver a amigos, así como a Vaccaro también, que hace mucho tiempo que presencialmente no nos vimos. Hoy para hablar con ustedes sobre el balance sagital y osteotomías. Pero yo diría que empezamos cambiando el título. El balance es una cosa que ni siquiera en el lenguaje original inglés se utiliza más. Es mucho más sagital alignment, que en español o en portugués viene para alineamiento sagital. Y creo que eso molesta un poquito. Entonces, antes de seguir, entrar en osteotomías o algunos conceptos, me gustaría mucho tratar de explicar algunas cosas. Cuando los antropólogos enseñan a los que dibujan y ven esos dibujos, lo que llama más atención es que aún para uno que no esté involucrado con la columna, se percibe como progresivamente desarrollaron también en el dibujo una lordosis lumbar. Yo tuve la oportunidad hace unos años de estar en el Museo Nacional de Nairobi, en Kenia, y por mi sorpresa vi como que muñecos de cera, ¿no?, que tenían una columna con una cifosis, son australopithecus, Homo rudolfense y finalmente Homo erectus. Y para mi sorpresa, los artistas hicieron la columna con lordosis, así que la lordosis aunque uno no esté involucrado en el estudio de la lordosis, es definitivamente un paso importante para mantener la postura en pie. Y ellos también demuestran en esta figura que me llamó mucho la atención, cómo la cola de un mono es importante para mantener el equilibrio, porque le tiene la cifosa. Nosotros no tenemos eso, pero tenemos una lordosis que nos ayuda a mantener el equilibrio. Así que el equilibrio de la columna también se explica muy bien por esta tercera ley de Newton, una presión del peso del cuerpo con el centro de su masa, hace una presión al suelo y tiene una respuesta igual, de igual valor. En la parte superior, es decir, la columna tiene que equilibrarse para mantenerse alineada con estos valores. Y por eso tiene las curvas de la columna, de las cuales más importante para mantener un equilibrio estático es la lordosis, que viene a compensar lo que existe por debajo de la pelvis, de la cadera, de rodilla y de pie. Y eso nos da un equilibrio donde la ergonomía nos permite mantener una posición como esta sin mucho esfuerzo o con la menor carga de esfuerzo posible. Cuando perdemos ese alineamiento y la columna se queda inclinada hacia adelante con el forward bending, tenemos que hacer un esfuerzo mayor para colocarnos en posición alineada, tratando de alinearnos. Eso es un gasto de energía que es fatigante. La pérdida de la lordosis lumbar puede ocurrir por un proceso degenerativo natural. Ven acá que el disco tiene una altura que se perdió con la degeneración de los dos andares. Eso nos da una postura de esta forma. Para tratar de evitar eso, o para compensar, utilizando nuestros mecanismos de compensación, hacemos una retroversión pélvica, que es lo que en algún valor nos permite alinear la columna, pero eso es bajo esfuerzo y muchos enfermos no consiguen salir de esta posición. Entonces, eso es lo que ocurre con un proceso degenerativo natural y por eso vemos tantos añosos curvados hacia adelante con la caída. Pero lo que nos trae mucho más preocupación es la pérdida iatrogénica después de la cirugía de columna lumbar. Esto yo vi en mi oficina el mismo día, la misma queja, operados por el mismo cirujano, y son de la misma familia, es madre e hijo, operación con 6 meses de intervalo. El cirujano no se da cuenta de lo que está haciendo, él no sabe lo que está haciendo, él ignora que son parámetros pélvicos, que son pequeñas fusiones, son 4, 5 en uno y 4, 5 en uno en la señora. Entonces, para evitar eso, hay una cosa que después les voy a hablar al final, pero para corrección de estas cosas no hay opción como en la degeneración senil, que tenemos que hacer ejercicio y algo se puede conseguir. Acá, en la iatrogénica cirúrgica, hay que hacer una nueva cirugía. Y estas nuevas cirugías son osteotomías o de Smith-Petersen, que es la parte posterior, o osteotomía de filtración pedicular. Bueno, esas cirugías son cirugías demandantes, pero son las soluciones que tenemos para la columna que falló, para el flat back, para la espalda plana. Y para conseguir un buen resultado, tenemos que tener una planificación muy buena y una evaluación adecuada del enfermo. Otra cosa, los enfermos tienen que estar bien avisados de las limitaciones y de los riesgos que una cirugía como esa trae, porque tenemos que hacerla bajo monitorización, por ejemplo. En resumen, es mejor evitar esta complicación y su solución con una buena comprensión de los valores de los parámetros pélvicos antes de la primera cirugía. Entonces, ¿cómo evitar? Avaliación pélvica completa. Comprender los mecanismos de compensación. Entonces, hacer una planificación quirúrgica adecuada y muy experta. Mire, muchas veces no tenemos una radiografía con el meato auditivo externo, como en ese caso, que se pueda trazar el eje vertical sagital o ver muy bien la cadera para hacer las mensuraciones. Bueno, por lo menos tenemos que tener una radiografía que incluya las caderas. Y así podemos medir la incidencia pélvica de esta forma, el pelvic tilt y el sacral slope. Y determinando la incidencia pélvica, sabiendo que la lordosis es la compensación para esta incidencia, podemos planificar una cirugía y decir, no, este enfermo es de riesgo, este enfermo tiene mucho riesgo para tener una espalda plana. Él está con la columna con dolor, con algún problema, pero si yo hago una cirugía, puede ser que yo tire o quite sus mecanismos de compensación. Veo un caso, por ejemplo, que se le operara en los años 80 por hernia discal, en los años 90 otra hernia discal, e en 2003 descompresión y fusión. Cuando miramos a la placa, ve que está una columna rectificada. Y es la principal forma de conseguir una degeneración del nivel adyacente. Él tiene ahora una estenosis 2-3, y después va a tener otra, y después otra, porque la degeneración del nivel adyacente es siempre presente, está siempre presente en la columna no alineada. La propuesta que el cirujano original, que fue siempre el mismo, ha hecho, extensión de la fusión. Pero mire cómo está el enfermo. No sé cómo tanto tiempo, 12, 15 años soportó esta posición. Para afeitarse tiene que doblar la rodilla. Y cuando miramos acá, vemos que hay una rectificación del sacro, una abertura y una rectificación de la columna torácica. Es decir, está utilizando todos sus mecanismos de compensación. Aumentar la fusión, yo le quito la compensación a ese nivel y voy a producir una degeneración adyacente más fuerte. El factor más asociado en la literatura con la degeneración del nivel adyacente, add-on, es un enfermo que tiene un desalineamiento sagital. Entonces, cuando mensuramos, vemos que este enfermo tiene una lordosis lumbar de 15 grados L4, S1, que es el más importante, y 29 en el total, para una incidencia pélvica de 45 grados, que es baja, y por eso él soportaba. Pero cuando aplicamos todos los parámetros y vemos su global tilt, estoy autorizado a hacer únicamente la cirugía del nivel afectado como una extensión. Bueno, cuando yo utilizo mucho el gap score, él viene con la columna severamente desproporcionada. El gap score es un muy acreditable método para evaluar la necesidad de una cirugía de mayor o menor porte. Y eso fue comprobado con algunos estudios, comparando la clasificación de Schwab con el gap score. El gap score parece ser más válido para nos dar una idea mejor. Ese es el trabajo original, si uno quiere tener después, él nos permite colocar valores como la edad, la incidencia pélvica, el sacral slope, la lordosis total, la lordosis segmental y el global tilt, que es esa medida, el mismo ángulo que va del centro de la cadera al centro de la placa del sacro, al medio, una que va a C7, en la continuación de esa línea. Ese es el global tilt. Son valores que cada año se descubre uno u otro valor que nos ayuda muchísimo. Entonces, colocado bajo el gap score, él nos da también la planificación preoperatoria. Ese enfermo necesita alrededor de 23 grados para tener una columna alineada, pero tiene una severa desproporción. Cuando ustedes aplican todos esos dados, colocando lo que se obtiene del enfermo, ustedes ven que no es enfermo para hacer una cirugía de extensión. Y eso me dice que yo puedo hacer una osteotomía de subtracción pedicular, que acá está, no tengo la placa total, porque con el COVID no es muy sencillo conseguir que el enfermo retorne para hacer una nueva placa, pero la corrección fue muy importante, el enfermo está bien físicamente. Miren esta otra enferma que tiene un dolor lumbar continuo, una falla de tratamiento conservador, medicación diaria, codeína, depresión. Vimos ahora lo que Alex falou. ¿Cuál es la chance de una cirugía ter suceso en un paciente que tiene codeína, depresión, com falhas do tratamento como esse tipo, muito pouca. E esta enferma que tendría que se someter a um tratamento de reeducação, ou a lo mejor uma única cirurgia, recebeu esta cirurgia. 1, 2, 3 cajas, e são cajas posteriores. Não é porque o vástago está doblado que tem lordose, não tem lordose nenhuma. Acá em la seta vocês podem ver a laminectomia, facetectomia, um mecanismo que não tem nenhuma necessidade, outra laminectomia, as cajas colocadas muito posteriores, cajas posteriores não permitem correção da lordose, subsidiência total de uma caja. É o juego de los 15 errores. E assim é começar a enferma. Colocamos o gap score, está severamente desproporcionada, pero como não tem espaço livre, ela tem que submeter-se para uma correção de 37 graus a uma osteotomia de subtração pedicular. Esta se vai operar ao mês que sigue, porque está com programação de cirurgia todo o ano, mas tinha muito medo do Covid. Agora em Brasil está um pouco menor, a maior parte dos enfermos vacunados, o hospital está com menor índice de infecções. Pero antes de operá-la, temos que ver os riscos para uma enferma, embora tenha uma depressão bajo controle, é uma depressão. Então, isso é muito importante. Há muitos textos na literatura, cada ano, em 2019, temos 2, 2018, 3, pero há que utilizar um score para determinar a qualidade do enfermo para suportar a cirurgia. Isto é dizer, uma avaliação completa, não da placa, pero do enfermo, é uma seleção do enfermo. Há que dizer ao enfermo, mire, você não é candidato a uma cirurgia dessa. Então, a planificação que tem como objetivo correção do alinhamento sagital, diminuindo o risco para uma futura revisão, tem que estar planificada de forma adequada. Um enfermo com flatback iatrogênico, uma artrodese 3 anos antes, um mismatch, uma incidência pélvica de 67 para uma lordose de 43, aparentemente porque se dobra um vástago, não é dizer que a cirurgia está, não é dizer que a cirurgia está controlada. E acá, 2 níveis de Smith-Peterson, extensão da cirurgia hasta T2, e ela pós-operatória imediata no hospital, enfermo com uma boa correção, 77 graus ao final. Isso é o que se consigue com a osteotomia de Smith-Peterson. É uma osteotomia de cierre posterior com o fulcro neste ponto. E há uma abertura anterior. Se eu tenho uma caja em 2, 3 níveis, não tenho como abrir, a não ser que tenha uma pseudoartrose, não tenho como abrir. Então, o Smith-Peterson não é uma osteotomia de ponte, como é isso, não? Ponte é uma osteotomia de Smith-Peterson. Smith-Peterson não é uma osteotomia de ponte. E se hace com... Não temos tempo, embora me pidan para falar de osteotomia, não temos tempo para dar-lhe o passo a passo, pero assim é. Um acesso mediano, identificação, passar um probe hasta o forame, remover toda a superfície posterior, e é muito importante que a dobra da mesa se quede com uma flexão exatamente no sítio de osteotomia para que você possa fazer esta correção. Isso é o que há de mais importante. Esse é o pós-operatório de uma enferma que tinha problema com isso, degeneração adjacente, o gap score. E vem depois a osteotomia de Smith-Peterson em 2 níveis. Uma outra enferma com desalinhamento sagital, muito difícil caminhar, 75 anos, risco, pero nos dije, assim não puedo viver. Essa cirurgia original, fizeram em 2012, na ampla laminectomia, por uma estenose 3, 4, 5, e 8 tornillos com um dispositivo que não serve para nada. Uma nítida retificação lombar. 3 anos depois, una degeneración del nivel adyacente y una escoliosis degenerativa. El cirujano le quita los tornillos debajo y le hace una extensión de la fusión porque, otra vez, el cirujano no entendió cuál problema tenía la enferma. Y le dice al final que tuvo un error de cálculo. ¿Qué error de cálculo? Eso es como está la enferma, como las vemos. Y toda la cirugía se basó en estas placas pequeñas. Nunca le hicieron una placa total, una panorámica de columna, un espinograma, para hacer la mensuración de los parámetros pélvicos. Acá nós vemos todo o que tem, uma fusão 5-1, hiperlordose foscal, retrolisteses, lordose torácica, utilizando todos os mecanismos de compensação. Aún assim, não consegue compensar a coluna. Então, com esse desvio de 16 centímetros do eje cervical, que fazer? Assim está enferma e com dolor, porque isto se mueve a pseudoartroses acá. A planificação basada en la posibilidad que tenía una señora de 75 años que estaba más o menos bien de salud, pero con una severa desproporción con osteotomía de subluxación pedicular, porque todos esos datos nos indican que tiene una necesidad de hacer una corrección muy grande. Entonces, la osteotomía de subluxación pedicular necessita uma resecção ampla do corpo através do pedículo. Há vários detalhes de técnica para hacerlo, são cirurgias mais sangrantes. A primeira parte de cirurgia não é mais que uma osteotomia de Smith-Peterson, não? E você vai sacando a vértebra com curetas bilaterais e com drills para sacar a vértebra, assim que você possa cerrar e conseguir uma ampla lordose, como neste caso. A identificar o processo transverso, identificação do espaço interespinhoso. Primeiro se colocam os tornillos, uma laminectomia ampla para impedir o impingement, quando se cierra a osteotomia, a resecção do pedículo hasta a base, a osteotomia hecha com drill, com formón, com Kerrison, e o que necessitamos é fazer uma abertura para depois cerrar o gap, não? E outra vez a mesa tinha que ter possibilidade de fazer isso ou com aloadas, alguma coisa que se pone previamente bajar o enfermo. Sempre monitorização, injerto e cierre. Esto que se conseguiu com a senhora esta. Vocês podem ver que é muito material, temos 4 haces para evitar, para controlar a pseudoartrose, pero ela está contenta. Eu não tenho novas placas, porque também por el COVID não vino mais. Habla comigo por web, por internet, mas está muito bem. Tuvo quase 6 meses de recuperação. Essa é uma placa de los 4 meses. Então, termino dizendo que há que fazer uma necessidade de avaliação do alinhamento sagital em cada um dos casos. Estes casos mostrei em Peru há poucos dias, em uma outra reunião clínica. Pero esta senhora tinha uma cirurgia, tuvo uma cirurgia discal 5-1 em abril de 18, seguiu com dolor lumbar, o tratamento conservador falhou, não viram os cirurgianos que tinham espondiolisteses 4-5. E acá está o pequeno agujero que fizeram para o disco 5-1, não melhorou nada. Em las placas dinâmicas tinha um pequeno movimento, então se mostra que é inestável 4-5. Tiene señales de Mori que diciendo que hay también razones para tener supuestamente dolor. No hicimos discografía, como Alex les contó hace poco. Hicimos mucho, pero no hacemos más. Y finalmente, es un caso sencillo. Hay que hacer fusión 4-5 sin cuestión. Pero por rutina, hacemos la evaluación de los parámetros pélvicos. Siempre. Y cuando pedimos una placa, ¿qué seguimos haciendo acá? Tiene un pelvic tilt, tiene colapso discal 4-5, 5-1, tiene una abertura 3-4, tiene una disminución de la lordose torácica. ¿Qué está haciendo entonces? O de la cifosis torácica. Tiene una lordose. ¿Qué es eso? Eso es utilización de los mecanismos de compensación. La señora trata de compensar la pérdida que tuve acá con estas otras maniobras. El cronómetro tocó acá. Entonces, tiene una distancia de 8 milímetros. Eso estaba en pleno COVID. Entonces, para no hacer mucha cirugía, eso es que está haciendo ella. Tuvimos que hacer, para una moderada desproporción y corregir apenas 12 grados, lo que temos que hacer en la cirugía de estabilización nuestra es la fusión 4-5 y 1 sin ninguna pérdida de los grados que tiene, porque 10 grados o 5 grados que la cirugía que uno va a hacer a menos no va a permitir que ella pueda compensar la columna. Entonces, en esta enferma, yo le diría que el enfermo de riesgo, ¿qué es el enfermo de riesgo? Es el médico que tiene posibilidad de compensar, mas este enfermo que tiene una alta incidencia, que tiene una lordose disminuida, contractura en flexión, con un cirujano menos alerta, es el enfermo que no es a prueba de médico. O el enfermo a prueba de médico es ese que puede compensar, mas la enferma que vimos, esa no puede compensar. Entonces, la cirugía de fusión se ha hecho con la intención de colocar las cajas bien anteriores, mire, bien anteriores, para no disminuir su lordose lumbar. Ella tenía 52 grados de lordose, está con 52 grados. Entonces, de incidencia pélvica, 58 para 52, un mismatch de 6 grados no es nada. Hasta 10 grados los enfermos soportan bien. Esta enferma, sem a evaluação dos parâmetros pélvicos, ela tinha um grande problema, porque o que conseguimos foi a parte mais importante, 4, 5 e 1, ampliamos a lordose. Então, a utilização de osteotomías para deformidades rígidas necessita uma avaliação clínica cuidadosa, monitorização e proteção dos nervios. Smith-Petersen se indica com coluna anterior móvel e osteotomías de 3 colunas quando a vértebra tiene que estar en el ápice de la deformidad. En resumen, siempre tomar placa de columna cervical, siempre mensurar de columna total, siempre mensurar los parámetros pélvicos, siempre calcular cuál es la lordose, siempre utilizar o gap score, siempre calcular el índice de fragilidad del enfermo, siempre evaluar el grado de osteoporosis y siempre, pero siempre, el más importante, respetar los límites nuestros y del enfermo. Bueno, muchas gracias por la atención y vuelva a transmisión total.
Profesor, muito obrigado. Muy buena exposición y el portuñol muy claro, maestro. Muchas gracias.
Necesito practicar más.
Al final de la sesión tendremos algunas preguntas de la audiencia para poder dirigirle y le pedimos que aún se mantenga con nosotros conectado, profesor Vialle. A continuación, nuevamente, tenemos la presentación del profesor Alex Vaccaro con el último tema de esta sesión magistral sobre cirugía de fracturas toracolumbares en el paciente anciano. Once again, Professor Vaccaro, thank you for you being present of this virtual Congress. Now in this opportunity, we will develop the topic of surgery thoracolumbar fractures in the elderly patient. You can share your screen, Professor. We will give you the floor. Thank you again.
You got it. Okay, here we go. Let's get rid of that talk. So again, Louis' talk, who I love, looked phenomenal. I just didn't understand it, but I have to begin using the gap score. I've read all the articles and the gap score, but I don't really understand it. So that looked like a great talk. So here's something that I've been doing for the last 30 years. And my favorite surgery is operating on the elderly, and my greatest complications are operating on the elderly. In fact, yesterday, my partner's sister, who was in her 60s, had a traumatic burst fracture and a conus medullaris injury and had surgery up in Syracuse, New York. And the surgeon did a great job. He did a transpeducular decompression, took the pressure off. He distracted like the typical AO technique, which gets me worried in an elderly osteopenic patient. And he put 2 levels above, 2 levels below. She walked around for 2 days and everything ripped out and she fell into kyphosis. So we had to reoperate on her. anteriorly, posteriorly yesterday. So it was a very difficult case. So this is what we're dealing with when we deal with people with osteoporosis, and this is what we see. So we look at where we're going in spine surgery. This is a famous quote from Dr. Milani in 2019. The field of surgery is growing. Will we look into new bioprosthetics? Will we look at new minimum invasive techniques? Will we do what Louis just talked about, the management of sagittal plane deformity? And I think what we're going to really do is we're going to have to figure out how to deal with elderly patients because of the medical comorbidities and osteoporosis, as well as the deformities. So these are the things we have to look at. This was the most recent paper I could find on trauma to the thoracolumbar spine in the elderly. This is 254,000 patients, and the vast majority deal with osteoporosis, and a small percentage, 1.5%, eventually went on to spinal surgery, and there was a high complication rate. Mortality, 2.14%, associated with older age, male sex, higher incidence of Charleston's morbidity index. So these are the things we have to look at. And we have to focus, number one, and we're not experts, but we have to be an expert on osteoporosis because everyone has it as they get older. It's expensive. We're coming out with new drugs every day. Those drugs are expensive. And I always get nervous when I deal with an osteoporotic patient on the use of cement, because cement, when it cures, it cures at 90 degrees Celsius. That causes localized osteonecrosis. And are there better biologics? And these are the things we have to look at. So when we get a typical X-ray of someone with osteoporosis, and again, as Luis said, you want to have long-standing films, you get the typical biconcave appearance, multiple levels of compression, and your heart just drops, especially in the setting of stenosis or deformity. How do you manage that? CT scans are great because CT you could use the Hounsfield units to determine the degree of osteoporosis. You could see the degree of canal compromise, and you could see if there's a pathologic lesion going on. And I think the best is with MRI. Remember, the early studies in kyphon and vertebroplasty showed that 11% of people that come in with what appears to be a benign compression fracture, when biopsied, may have a malignancy. So we look at, does the edema go into the pedicle? Do you see the transverse sentinel fracture line? And these are the things we have to look at when we look at someone with an imaging fracture. And once these patients present to you, you have to get your team involved. You either have a medical individual endocrinologist, or you have to have an orthopedic surgeon, non-op, who specializes in it, because we have to start working on their osteoporosis. So what do we do as surgeons? I'm not a big fan of vertebroplasty or kyphoplasty early on. After 6 weeks, I'll consider it. But do I put them in a brace? Is the brace difficult to wear? Do I get them up? Do I walk them around? Always get standing x-rays a week later. These are the things that I have to go through. And then, as Louis talked about, the GAP score, there's tools out there online that look at risk assessment. You want to take an elderly gentleman who's 80 to the operating room. At my level of surgery, I just have an intuition. I know the medical background, but you can go on to eprognosis.org and figure it out on what's the likelihood of this patient having a complication. So medical doctors look at the medicinal side of it, look at the appropriate laboratories studies, make sure, like the patient I operated on yesterday, I said, we got to get you on Forteo, we have to do a DEXA scan, we have to figure out exactly what's going on. That is a given. You have to do that no matter what, but you have to be plugged in. And I would work on it now if you're in practice. Have this set up in your practice. And we know that vertebroplasty and kyphoplasty does well. I always laugh when the American Academy of Orthopedic Surgery came out 5 years ago and said, you can't do vertebroplasty, it doesn't work, you can only do kyphoplasty. That's not true. It was a biased group of patients being looked at by industry. Both vertebroplasty and kyphoplasty can give patients a sense of comfort. They can make them feel good, but there's complications. You're not going to get any deformity correction. I mean, don't get caught up in the whole balloon thing with kyphoplasty. It's not really going to help you. The balloon is just to decrease the potential for the cement to extravasate. That's, for me, that's what it's done. But they're coming up with newer technologies that will prevent that from happening. So pain relief, yes. VA score improvement, yes. SF36, it gets better. But you got to keep in mind, and this is why I'm not a big fan, you have complications. You have osteonecrosis, you have adjacent level fracture, you have cement extravasation. And I still remember the case, it was 11 years ago, where 2 patients in a hospital in America died on the same day because of multi-level vertebroplasties with cement monomer transferring through the bloodstream, not extravasation, the monomer, and then it formulated in the lungs and it solidified. And 2 patients died in the same operating room. So keep that in the back of your mind. Now, if you decide to go beyond kyphoplasty, I mean, you could use kyphoplasty and vertebroplasty to support whatever you do, but we would prefer in these patient populations to do anything you can in a minimally invasive manner, avoid long constructs, just stabilize the patient, et cetera. And I'm not talking about long-term deformity correction. These are the things that we want to do. So the principles we use is, if you're going to use fixation, multiple points to decrease stress. Take the stress off. Hopefully the patient will be aligned. Use cement sparingly if you have to. And then minimize the patient going crazy after surgery. Get them up, get them moving. Treat the underlying disease. You can go anteriorly, you can go posteriorly, you can go combined. And I'll go through each one with you now. Anterior surgery is great to decompress the neural elements, but it's not great when you have to put a piece of graft where there's a modulus mismatch and you lengthen the spine. So anterior surgery in the elderly, fraught with complications. I had to do it yesterday because everything fell apart. I needed anterior column support. But deformity correction, bad idea, especially with the graft that has a mismatch. So modulus mismatch is going to get you in trouble. And if you look at all the things that are available, what I like is I'd like to use an iliac crest allograft with a low modulus because it matches somewhat the modulus of the vertebral body bone. The largest footprint possible that you can get, and that is exactly what you want to do. And if you make the mistake of thinking anterior fixation is a great idea, understand that unicortical screws are not as good as bicortical screws. A bicortical screw with a staple is better, and bringing the screw as close to the end plate is the best. And that's what you want to do. So you look at screw size is totally different than posteriorly. Screw size anteriorly really doesn't change the equation, but triangulating the screws does change the equation. Now, posterior is easy, and we have a lot of things. We have wires, we have tapes, we have hooks, we have pedicle screws. I like to shorten the spine rather than extending the spine. But remember, screws pull out, and they sort of pull out in a cantilever effect. That's embarrassing. So as we get older, the pedicles enlarge. We have the cancellous bone is weaker, so we have to keep that in mind. And we know the pull-out strength decreases exponentially in the setting of osteoporosis. So keep that in the back of the mind. So the points that Louis had talked about and the points that we have to think about is just use the typical deformity principles. Don't stop at a junctional level at all. Use multiple levels of fixation. If you're going to go down to the pelvis, consider pelvic screws, because the worst thing you can get in a patient is a sacral insufficiency fracture with translation. That patient will hate you forever, even if you go back later on and fix them. So think short or think multiple levels of fixation. And when you use screws, make them long. The longer, the better. Most of the fixations in the pedicle, but the longer, the better. I don't tap in elderly patients. I don't take the screw out because I lose the torque insertional strength if I take the screw out and I replace it in. And remember, the outer diameter minus the inner diameter gives you better fixation in cancellous bone. And you want to grab the cortices of the pedicle when you put the screw in itself. A conical screw is even better fixation. The problem with the conical screw is you back it up one thread. Did I just go off mute again? I don't even know why. I don't know why that happened. So a conical screw is even better but you can't back up a conical screw at all. And that's a problem. Now, expandable screws, I think, are great because, and if you look at this graph, it gives great fixation in bone. The problem with an expandable screw and the problem why it has not been FDA approved is how do you revise it? You can't collapse the screw. And it's not predictable because bone will grow inside. I mean, you can collapse it, and then if it pulls out, the FDA is afraid it's going to disrupt the neural elements posteriorly. I think it's a great technique if you can do that. Now, I rarely place hooks. The only time I place hooks nowadays is if I place hooks in a fusion mass, because I did them all the time in the 90s, but I never do them anymore. And if you look at the biomechanics, a double claw is better than a screw and a single claw. And we've looked at different studies. This is the Hillebrand study, my partner, where he revised the screw and then had a hook at the same level. Now, that's confusing nowadays to figure out how to do that, but it shows that it increases the strength. I rarely ever use it, but it's an opportunity. I am a big fan of sublaminar wires. I rarely use them anymore, and I'm afraid if I have to use them, that my operating room may not have it. But when I was younger, I would follow the Mark Asher technique of deformity surgery of putting a stable construct proximally, distally, and bringing the curve to a contoured rod. But it also, because the posterior elements, and he wouldn't just place his rod in the sublaminar space, he would do it in the subpars space, which is even more interesting. It does cause frontal stenosis, but it allows you to bring the spine over, so which is great. Now, what do you do when you have instrumentation failure? That patient that I had yesterday failed. I didn't put cement in the pedicle. Everyone puts cement in the pedicle. I'm just not a big cement guy, but I probably should have put cement in the pedicle, but I decided to use multiple points of fixation and go anteriorly. Now, there's more expensive technologies out there. You can coat the screw. You even have a condom that goes over a screw that sort of enlarges the screw itself, and that's fine. But these screws are very, very, very expensive to use. And if you look at cement, just putting 2 cc's in cement, you increase the pull-out strength 500%, 3 cc's, 600%. But again, 2 headaches, exothermic reaction causing necrosis, and the risk of extravasation. So the pull-out strength is there. I'm not a big fan, but it's a great way of doing it when you want to do that. And now they've developed screws that have little fenestrations in it just to give you more stability. More technology is being developed where the cement just doesn't come out. The cement is grabbed by another membrane that allows it to go up but not as far. That's what we need to do. We need to develop technologies that allow us to put it in, not rely totally on fluoro to make sure there's no extravasation, because once you see it extravasating on fluoro, the damage is done. So keep that in the back of your mind. Now, do you go short and do you go long? I like to go short if possible, but long if I have to because of the amount of instability. And this paper was just studied that looked at short segment fixation, was great in minimal comminution, and the alignment's okay. But once you need to do any type of gentle correction of alignment, you need multiple points of fixation. And the short segment had more complications than the long segment. So keep this in the back of your mind. So here's an example, 68-year-old patient, multiple medical comorbidities, significant osteoporosis, and a pathologic fracture causing pressure on his spinal cord. So he has a spinal cord injury, so you're not getting away with operating. And in this situation, you can go posteriorly, you can do a transperpendicular decompression, take everything out of the canal. So, and cement, and this works out great. Now, you can even use the argument, you can remove the pedicle and shorten the spine, which I like even better. And if you shorten the spine, you can put an allograft, iliac crest allograft with a module. I like that even better, but this is an acceptable way. So combined approaches, I did it yesterday. I do it when I have really bad instability and I have a gap there that I can't shorten. I will use it, again, thinking about the modulus of the graft. Now, here's an example of a patient, pretty straight, osteoporotic burst fracture. The surgeon follows the patient over time, non-op, 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 but the patient settles into kyphosis, has further stenosis, and develops a neurologic deficit. So now the surgeon wants to do something. So the surgeon says, I have to intervene. The patient has bound bladder. So he says, where's the pressure? The pressure is anteriorly. Now, the optimum approach is a posterior approach, removing all the fragments and just putting a little bit of a allograft bone posteriorly, if anything. That's the choice. The surgeon decided to go anteriorly because he reasoned the pressure is anteriorly and the x-rays look great. But when you follow that patient over time, it's going to fail. It's going to fail. It's going to fail. And you have to go posteriorly to stabilize the spine. So one last topic is BAER, B-A-E-R, balloon-assisted implant reduction. I don't do this. This is popular in Europe. Minimally invasive decompression, screw above, screw below, use a balloon to elevate it. And the only study that I really found that looked at it showed that it does much better than just either a decompression in single level above and below or kyphoplasty alone. So it's out there as long as you can protect from cement extravasation. And again, this is not an acute, this is not a deformity case, which Louis just talked about. But if you're going to do deformity correction, multiple points of fixation, you may want to supplement the screws with cement, but shorten the spine. Don't lengthen the spine because you're going to get into trouble. if you look at the papers that look at the elderlies with neurologic deficits, if you clearly look at this study, anterior approach, posterior approach, anterior posterior, the neurologic improvement is guarded. The complication rates are high. And there was 2 papers that looked at neurologic compromise. And again, if you look at the implant failures, I mean, 14 patients had anterior approach, 9 patients had a posterior approach, implant failure 6 out of 9. So you're looking at 70%. And they did improve neurologically, which you would expect in an incomplete lesion, but you got to be careful with surgical intervention in that setting. And the last thing is, once you operate, you just don't walk away. You have to look at all the different things you can to get the patient more involved in their rehab, stimulate the mind, make sure they have appropriate nutrition, make sure they're getting the appropriate medicinal treatment for their osteoporosis. And your hospital needs to have treatment programs for the elderly, because that's what we're seeing more and more and more. And it's not uncommon in my hospital to operate on an 80-year-old after an odontoid fracture. So you have to have all this set up so these patients can be comfortable in the hospital. You want to get them out of an acute hospital as quickly as you can. So keep in the back of your mind, it's all about complications in this age group. Complications of implant failure, graft subsidence, adjacent level disease. Keep it in your back of the mind. Again, treat them non-operatively. All patients that come in with a symptomatic compression fracture, I don't run right to kyphoplasty or vertebroplasty. Exercise, get them up, nutrition, minimize narcotic medication. And if you have to operate, use the principles we discussed in this talk to minimize your chances for adverse complications. Thank you.
Thank you very much, Professor, for your brilliant presentation. And first, excuse me, do you have a translation option in English on the Zoom platform?
I do not.
You can see it.
I do not. So if someone types it in the chat box, but or if you can,
Okay.
if you can translate, that'd be great.
Okay, Professor. We can invite everyone present to ask their question on the platform to send them to the teachers, or if someone who wants to give a comment in an open way, we can also do it. Seguidamente invitamos a todos los presentes a realizar sus preguntas en la plataforma para hacerlas llegar a los profesores, o si alguien que quiera dar algún comentario de manera abierta también lo puede hacer. Professor Vaccaro, in the chat we have a question.
Yeah, sure.
About your first topic. In your experience, how are the results of ozono or radiofrequency therapy in degenerative disc disease?
So radiofrequency ablation, I'm a big fan, not because it works, but because it's not morbid. So I'm a big fan. And if a patient wants to do it, I'm like, go ahead and do it. And I pray they have the placebo effect and they feel better. I pray, because it's not my headache, it's low morbidity, but all the studies give it about a 60% success rate. So if I give the patient a placebo, a salt pill, to have the same, but I'm a big fan of it because it doesn't hurt a patient. Big fan.
Okay, doctor. I have another question to you. But first I'm going to talk in Spanish. Otros estudios, por ejemplo, en cuanto a aparte de la resonancia magnética, como por ejemplo la mielografía, la resonancia con carga o electromiografía, ¿qué tan importante le da para usted esa indicación? Other studies than MRI, such as myelography, load MRI, or electromyography, how important is their indication for you, Professor Vaccaro?
So MRI is my go-to study. I rarely get myelogram CAT scans. I hardly ever get them. I only get them if I have to, if I can't see the neural elements, if someone has foraminal stenosis after instrumentation. So not a big fan. I don't like radiation from CT scans. I'm not a big fan of CTs in any degenerative process. I know people use them all the time for bone quality or Hounsfield units. So MRIs, I use EMGs when I have a headache, when I have a metabolic process that I want to differentiate. Does a patient have diabetes? Does a patient have a peripheral neuropathy? Does a patient have CIDP, a sensory motor degenerative process? and again, I'm not the guy ordering the EMG. I suspect problems going on, so I send him to a neurologist who does the EMG. And I'll tell you a few things. I've been burnt in my career, and I've been burnt later on in my career operating on people with severe lumbar stenosis, and they got weaker after surgery. And then they said, oh, he has a progressive sensory motor neuropathy. And I'm like, what is that? CIDP. I had no idea what it was. And then they gave him IgG, and the guy walks into my office 2 weeks later. So in that setting, an EMG is great, but I didn't really understand it. I just, because I got burnt a couple of times, and that's how I got burnt. So diabetes, if you have a palsy that's with no symptomatology, is it a virus? I'll go with EMGs, but in general, I don't use them.
Okay, thank you, Professor Vaccaro. We have another question. En pacientes con osteoporosis, ¿es mandatorio realizar la densitometría ósea o se puede tomar decisiones con la medición de las unidades Hounsfield en la tomografía para la vértebra L1? In patients with osteoporosis, it is mandatory to perform bone densitometry, or decisions can be made with the measurement of the Hounsfield units of the tomography at L1.
So in our Medicare system, we have something called MIPS, MIPS. It's how we get paid. And you have to get a DEXA scan after a certain age. So if you're taking care of the Medicare population, which is the federally insured, you have to recommend every patient over a certain age or any person with a risk factor has to undergo a DEXA scan. Now, the Hounsfield units have never been FDA approved as a method of determining osteoporosis. And a lot of the radiologists don't list it. But I love the radiologists. I asked my university to list it, the Hounsfield units, and interpret it, because you and I are not radiologists. So, you know, I don't know what it means. So I've asked my radiologist, what are the Hounsfield units, and interpret what it means for me so I could tell if the patient's osteoporotic. And you're right, L1 is the level to do, because if you go down the lower lumbar spine, you'll get confused by the pelvis and the femoral head and the proximal femur. So that's how we handle it at my university.
Okay, doctor. We have a last question for you. En un paciente mayor, ¿no? En este último tópico, con una conmoción compleja del cuerpo vertebral, pero que el dolor es controlado, no tiene deformidad, pero que se espera que tenga una mala evolución clínica se espera que tenga una mala evolución clínica para recién realizarle la cementación de la vértebra. In an older patient with complex comminutation of the vertebral body, but with controlled pain and without deformity, it is necessary to wait until he has a bad clinical evolution before performing cement augmentation?
I'm not a big fan. I'm not a big fan of cement for many, many different reasons. And my reasons are that I'm at a university that gets patients that have had complications with cement sent to me. So if your question is asymptomatic patient with good alignment, I would never do cement in that patient. I would just, that patient, the argument is, should you wear a brace or no brace? And elderly patients hate braces. I put them in a brace anyway. And I don't even know why I use a brace, because every study that comes out says it doesn't work. I still do it. So I'm an old man of old traits, but yet you start sticking cement in people, and 1 to 3% of the time you're going to get burnt. So use it when you have to. Someone's miserable, someone's not getting out of bed, someone's favoring narcotic medication, someone's not eating. I'm okay with it, but don't do it prophylactically, because you're going to get burned, and then you're going to feel really bad.
Okay, Dr. Vaccaro. Thank you so much for the answer. Doctor Vialle, tenemos algunas preguntas para usted. Sí.
Before Alex leave the web, I want to take the opportunity to say hello to him. It's nice to see you again, Alex, even by the web. Unfortunately, we can't see each other as before, but I know that you are doing well, and I'm glad for that.
And it's great to see you, Louis. I can't wait to get together with you, your wife, and your son as soon as possible.
I hope. Ok, entonces, ¿cuál era la pregunta, José?
Sí, doctor Vialle. En el chat tenemos una pregunta del doctor Laos. Teniendo en cuenta la duración y la complejidad de la cirugía, ¿cuáles serían las circunstancias, ¿no?, en las cuales no le daría la opción de cirugía, en este caso las osteotomías, a un paciente con un desbalance espinal, ¿no? Como por ejemplo comorbilidades, la edad, etc.
Entonces, es una evaluación preferencialmente con el gap score, teniendo en vista la cantidad de cirugía, el porte de la cirugía que yo necesito, el cuántos grados necesito. El más importante es la comorbidad, no es la edad. La comorbidad es todo, si es un infartado, un trasplantado, si es diabético descompensado, si es un fumador que es irreversible, si tiene osteoporosis muy pronunciada, hago la cirugía, pero va a fallar en 1 o 2 meses. Entonces, las comorbidades son más importantes. Y para eso, Eduardo, hay índices que usted puede elegir uno de los que hemos. Hay muchos publicados. Nosotros estamos siguiendo un nuestro, que es una condensación de todos, porque tuvimos muchos problemas con enfermos que no parecían tan graves en su comorbidad, mas con malos resultados, hasta algunos fatales. Entonces, para hacer con el volumen de cirugía que hacemos para corrección del desbalance, del desalineamiento sagital, la comorbidad es lo más importante. La edad no es una limitación. Un enfermo añoso que tiene 80 años, él está muy bien de salud. Lo que tengo que juzgar es si él va a soportar o necesario es una cirugía muy grande. Mas para esses enfermos que son muy añosos, usted puede elegir una cirugía menor, o sea, si tiene una estenosis pronunciada, hacer una descompresión pura y dejar que continúe con su desbalance, o si tiene una instabilidad como una lateralistesis muy grande, que algunos se quejan mucho de eso por dolor, hay que hacer entonces una fusión corta. Entonces son situaciones donde usted puede hacer pequeñas cirugías mínimamente invasivas, percutáneas, no considerando el desbalance. Pero estos enfermos van a quitar el dolor de la estenosis o de la inestabilidad, pero van a quedar con el dolor en la espalda, caminando mal y desalineados. Y si viven mucho por encima de su cirugía, van a tener una otra complicación.
Muy bien, doctor Vialle, muchas gracias. Tenemos una mano alzada del doctor Alfredo Vázquez, neurocirujano de acá de Lima. No sé si quedará abrir su micrófono o... Doctor Vázquez.
Yo lo veo a Alfredo con la mano.
Sí. Bueno. Hasta
Hola, ¿me escuchan? ¿Me escuchan?
Sí, doctor, le
Hola.
escuchamos.
Buenos días a todos. Buenos días, Luis. Un gusto escucharte por este medio.
El mismo digo yo.
Los casos que tú muestras son casi todos iatrogénicos.
Sí.
Y muestras una herramienta para el cálculo de la corrección que se puede hacer quirúrgicamente. Este cuadro que tú pones, esta herramienta, ¿es un software? ¿Es una herramienta a la cual se puede acceder? ¿Y ya es automáticamente cómo te da las correcciones? ¿Cómo funciona esto? Quisiera que tú compartas esto para que no cometamos más errores y no aportemos más pacientes a la cirugía. Gracias.
Sí, claro, eso es muy importante, por eso, porque el gap score se puede conseguir por la internet. Y yo estoy buscando acá, para mostrar otra vez para ustedes acá. ¿Se me permite compartir la pantalla? Acá. ¿Lo ven? ¿Ves, Alfredo?
Sí, Luis, acá escuchando.
Esse está en 2017 de Journal of Bone. Usted puede buscar. se no me falla, este es un artículo que está libre para acceso, pero se puede ir al Gap Score en la internet y accesar www.gapscore, conseguir con eso. Yo no sé si consigo colocar acá colocar para ustedes todos a ver si consigo el Gap.
Luis, entonces podemos decir que es una herramienta de acceso libre, de acceso gratuito, de fácil acceso, de fácil comprensión y a la cual todos podemos acceder.
El GAP, me puede escribir acá en el chat. ¿Qué consigues? El GAP calculator.com. ¿Ves?
El Gap Calculator.
Y con eso, van a la pantalla del Gap Calculator y consigue inmediatamente eso. Y ustedes pueden poner los datos, la edad y todo más, ¿no? Pueden mensurar con el Search Map. Y ahí entonces te consiguen una perfecta evaluación del enfermo para tratar de no cometer errores. Muy buena pregunta, Alfredo. Gracias por la oportunidad de mostrar eso con ustedes. Hacemos esto rutinariamente, siempre. Bueno, puede ser que tenga alguna falla, pero los estudios mostraron que el GAP es muy indicativo de la cantidad de corrección para usted decidir, no voy a hacer una cirugía menor o mayor. Gracias por la cuestión.
Gracias, Luis.
Muchas gracias.
Cometeremos menos errores ahora.
Sí, justamente eso para recalcar, ¿no? Que justo estos parámetros ideales están basados en estudios poblacionales, ¿verdad, doctor Vialle, no? Y existen múltiples plataformas virtuales que al introducir los valores nos dan ya todos los resultados, ¿no? Como el Spinometrics, el Gap Score, ¿no? Doctor, y una última pregunta. ¿Qué hacer en estos dos escenarios? En pacientes que tienen obesidad central, ¿no? Que obviamente no tienen una buena evolución, ¿no? Cada vez que instrumentamos la columna lumbar, sobre todo, por ejemplo, en L5, S1, limitados los mecanismos compensatorios, al final pueden llegar a síndrome de espalda fallida. ¿Qué otras contemplaciones específicas en estos pacientes en cuanto al desbalance sagital? Y el otro es sobre los pacientes que tienen el síndrome columna-cadera o cadera-columna. ¿Cuándo primero operar, no? Si primero nos enfocamos en el aspecto de la columna o luego la cadera, ¿no? Como sabemos, cuando se opera primero la prótesis de cadera, luego la columna, modificando así los parámetros espinopélvicos, esta prótesis sufre, ¿no? Hay pérdida de la cobertura y los desplazamientos. Por eso que algunos cirujanos de cadera, porque acá también tenemos traumatólogos, ¿no? Con los de la columna deben de trabajar de manera coordinada, ¿no? Para tener justamente los mejores resultados funcionales para los pacientes.
Bueno, ya no me olvido más de su primera pregunta. Así que voy a contestar la última. Yo creo que tiene que decir a Alex que él puede buscar en Interpretation. Alex, you can find down there in Interpretation, you can have the translation for English maybe. No sé si él tiene traducción para inglés.
So I can get a translation on Zoom?
You go down there when there is share screen, there is a globe of interpretation. You click on there, you'll have the English translation or Spanish translation.
Oh, I'm going to have my IT guy try to figure it out. That's great. I'll definitely do it.
You just click and you have the translation. Entonces, José, cuando tenemos un enfermo con cadera con artrosis, ¿cuál es el problema de la cadera? Una artrosis que limita la función y que progresivamente hace una flexión de la cadera. Y la flexión de la cadera empeora el forward bending. Así que no hay como hacer una cirugía de corrección de la deformidad de la columna antes de la cadera. Lo importante es empezar con la cadera. Y el cirujano de cadera haga la prótesis de la forma ideal. El otro, el revés, un enfermo que tiene una cirugía de columna y el cirujano de cadera va a hacer una hip replacement. Él coloca la taza, la copa, en la misma posición usual. Esta cadera se va a alojar. Entonces, si hay una columna operada, equilibrada, con una buena lordosis, él no tiene con qué se preocupar. Pero si no hay una lordosis, el cirujano de cadera tiene que colocar la taza en una posición distinta. Hay muchas publicaciones. Hoy mismo surgió una publicación recibida de European Spine Journal de colocación de prótesis y luxación. Entonces, para nosotros, cirujanos de columna, nunca operar una columna si tiene una flexión de cadera. Resulta que no va a dar cierta la cirugía. Hay primero que hacer la cadera. A ellos, para los cirujanos de cadera, si tienen un enfermo operado, hay que se dar cuenta que la posición de la copa va a ser distinta o va a tener desplazamiento. Esa es una de las preguntas. ¿Qué más preguntaste, José?
Sobre la obesidad central, si hay algunas
Sí.
consideraciones especiales.
Mire, obesidad. Esa es una comorbidad. Índice de masa corporal muy, muy grande. BMI. No se puede hacer una cirugía. Entonces hay que cuidar para evitar una cirugía en esos enfermos. Pero si tenemos un enfermo que no tenga obesidad, pero que tenga un sobrepeso, y hay que hacer una cirugía, hay que cuidarse de los parámetros. Y para el 5S1 es mucho más sencillo con ALIF, el 5S1. Yo veo unas charlas en Estados Unidos que dicen, el 5S1, ALIF is king. Entonces, esa es la palestra, la charla que dicen, para el 5S1, ALIF siempre. Se abre, se hace la corrección, es menos cirugía, no hay tanto preocupación con pseudoartrosis, con tornillos, con cirugía mayor. Entonces, para los enfermos muy obesos, yo diría que están en el enfermo que yo voy a recusar una cirugía de corrección. No son los enfermos para eso. Y hay también que pensar en los enfermos que hacen cirugía bariátrica. Ellos tienen una alta tasa, una mayor tasa de infección, de esencia de la sutura. Entonces, yo diría que nosotros tenemos que tratar de enfermos que puedan tener un beneficio del tratamiento. Y no que coloquen en riesgo nuestra reputación, nuestro servicio, nuestro hospital y su vida.
Muy bien, doctor Vialle. Qué gran oportunidad que hemos tenido en poder compartir con dos grandes referencias internacionales y expertos en cirugía de columna. Thank you again, Professor Vaccaro, for being with us. We invite you to the next events and for the next time to be in person, to be able to invite you a pisco sour and ceviche for flan dish of Peru. Igualmente, doctor Vialle, agradecidos por su participación y esperemos de que podamos contar con los próximos eventos con usted y que esta vez sea de manera presencial y poder invitarle un buen ceviche con un pisco sour.
Claro,
Thank you for
siempre.
us. Por horas del tiempo, continuamos con la siguiente sesión, doctor Laos. Creo que culminamos con esta sesión magistral. Gracias a todos.